Presenting the case of Mr. KS, 70-year-old male, resident of Dhanbad, Jharkhand.
मैं आपका ईयर कौन सा है?
Sir, third year.
Third year. Okay.
Lawyer by occupation. History was given by the patient himself and his wife, and the reliability is good.
Sorry, age क्या बताया आपने?
Sir, 70.
Okay.
He is a renal allograft recipient of March 2017 and presented to our hospital with complaints of easy fatiguability for 2 months, lower backache for 1.5 months. I would like to begin my history from 2010 when the patient was 57 years old and he was diagnosed to have hypertension. As per him, his kidney functions and the urine tests were normal at that point of time. The patient was started on single antihypertensive agent. No follow-up blood tests were done from 2010 to 2014. In 2014, patient started experiencing frothiness in the urine, increase in the frequency of urination at night associated with mild pedal edema. This was associated with easy fatiguability and generalized weakness. There is no history of any decrease in the urine output, flank pain, burning micturition, blood in the urine, any shortness of breath, orthopnea, chest pain or cough. No history of fever, skin rash, joint pain or any alternative mode of medication intake. For these symptoms, he got evaluated and was detected to have serum creatinine of 4 mg per deciliter and his hemoglobin was 10 gram per deciliter at that point of time. He also underwent an ultrasound abdomen and was told to have bilaterally shrunken kidneys.
Okay.
The patient was started on tablet iron, calcium, antihypertensives were up titrated and he was started on a weekly injection to increase his hemoglobin. Over next 2 years of follow-up, his kidney functions progressively worsened to a value of around 9 mg per deciliter and his urine output also progressively declined. However, there was no requirement of any blood transfusion during the course of his illness till this point of time. He was counselled regarding the need for renal replacement therapy and vascular access creation and was provided various options for renal replacement therapy. He opted for renal transplantation with the prospective donor being his son. Donor's age was 41 years and he had no comorbidities. The blood group of the donor as the recipient was B positive.
Okay. Just a second. From 2010, he was diagnosed of hypertension, right?
Yes, sir.
From 2010 to 2014, there was absolute no symptoms?
Sir, he was not on any follow-up and he was on single antihypertensive. No symptoms.
No symptoms.
Only single antihypertensive agent he was taking.
And what happened in 2014? He had frothy urine.
He had frothiness of
shortness of breath.
Edema and shortness of breath. Sir.
What was the timeline of that? Was it a gradual event or it happened within 15 days?
No, it was gradually progressive, sir. Over a period of 1.5 to 2 months, he said this has started.
Okay. What is the importance of knowing this?
So we want to rule out if there was any acute event leading to acute increase in the creatinine. Was it a RPRF like presentation? Was it AKI on CKD? Or was it progression of a chronic kidney disease?
Okay, so with that history, what do you feel it is?
Since
1 to 2 months is like days to weeks, right?
Yes, sir. In days to weeks, still the possibility of rapidly progressive renal failure cannot be ruled out. But since we don't have any follow-up blood investigation in the last 4 years, so we do not know what was the timeline of starting of his, the worsening of his kidney functions. To begin with, he came with 4 creatinine, sir.
Okay. One more thing which actually will help you more. The moment within the history, if you commit to creatinine 4, ultrasound small kidneys and a low hemoglobin, you have already gone to the diagnosis of CKD already in your mind and probably in your audience's mind. तो आपने AKI, RPRF और CKD के बारे में सोचना ही बंद कर दिया. This could have been RPRF, ना? Within 4 to 6 weeks it has happened.
Yes, sir.
For 4 years nothing was happening.
Yes, sir.
So over 4 to 6 weeks suddenly what will happen? Can hypertension itself, this is non-diabetic, right?
Non-diabetic.
So what has happened in the 4 to 6? Does hypertension has caused this?
Sir, I asked about any accelerated episodes of hypertension during this time, but there was no history of any accelerated episode of hypertension also.
Okay. What else?
And there is no history of any acute preceding intake of any alternate mode of medication or any other antibiotic intake or any urinary tract infections preceding this, any history of skin rash or vasculitic lesions, but nothing was there, sir, in the history.
Okay. What suggests CKD in this? Historically, not that report-wise. What all did you ask nocturia?
Yes, sir. Nocturia was there.
In 2014?
In 2014, when he presented with this complaint of frothiness of urine, he had nocturia. and he had
Okay,
pituitary.
so since when he has this nocturia?
This he
Like,
said
this
he
becomes
was.
very important. History is very important. Going to diagnosis, transplant हो गया जी, उसके बाद ये हो गया वो, तो you will do this all your life. As a student, our job is to find this. A physician and all other people are going to do the standard treatment जो आप करने वाले हो. आपका difference यही है सीधा 2014 में. To prevent that, तो आप already 4 creatinine और ultrasound को देख के if you have made a diagnosis कि ये CKD है और जहाँ भी आप हैं for whatever reason suddenly dialysis और आपने transplant बोल दिया, तो that is not the job of a nephrologist. Our job is to revert the primary problem, diagnose the primary problem. That has all the consequences. Even if you are unable to treat the primary problem, if you know the primary problem, it will help you in transplant, in recurrences, plus how things have behaved. So you find it a little fishy. In 2014, within 4 to 6 weeks, he was absolutely fine, and suddenly in 4 to 6 weeks, he has gone to creatinine of 9.
Creatinine of 4.
Creatinine of 4.
Yes,
so from 0 to 4, 4 at the age of 57 is like 15% of kidney functions are remaining.
Yes,
so, what is the differential diagnosis for this as a primary disease? Let sir come, we will discuss about transplant after that. Let's discuss about this. What is the differential diagnosis for this current problem when he got CKD?
Sir, given the timeline of onset of the symptoms within 1.5 to 2 months duration, I would like to keep the possibility of a rapidly progressive renal failure. But since we do not have a baseline creatinine values for the last 4 years, we do not know what was his baseline creatinine levels. Second, there is a presence of anemia, presence of small size kidneys. So there is a possibility that this was an acute or chronic event. Second possibility would be that.
Okay. Again, we have to go through history. You have made a diagnosis of CKD based on creatinine ultrasound in this.
Historically,
हिस्ट्री में जाओ वापस से आप कि ये RPRF में और क्या हो सकता है, तो डिफरेंशियल में क्या वो if somebody coming at 57, 4 to 6 weeks of short duration history, apparently all right and became creatinine 4. So what is the differential for that? Don't go for the investigation.
Sir, historically, there is no history of any decrease in the urine output, acute decrease in the urine output, no history of any shortness of breath or significant volume overload, and no history of any exacerbation of the hypertension in the preceding few months. So these things are going against the possibility of a rapidly progressive renal failure. And he had history of nocturia, although he says it was there since last 2 months, but we don't know for how long it was there.
Okay, let's get to that. Anybody, what is nocturia? कोई थर्ड ईयर है? थर्ड ईयर है कोई आप लोगों में से? आप हो? थर्ड ईयर हो मैम? What is nocturia?
The total volume of urine that is being passed at the time of the night is more than 50% as compared to the total volume which is being passed in the whole 24 hours.
Okay. Any other definition? I think there are 2 or 3 in written somewhere else. 50% in the night, more than 50% in the night, that those 8 hours.
Yes, sir.
Okay. How do you ask history for nocturia?
So we usually ask the patient if there is increased nighttime awakening to pass urine, and as opposed to the previous habits of the patient. If patient requires more than one nighttime awakening for passing of urine, then the increase in frequency as well as the volume of urine, that how much times he has to get up in the night, those 2 things we will ask. And if this patient has increased frequency of urination in the night time as opposed to his previous activity, or if there is increased amount of urine that is being passed in the night, that is out of the total amount of urine, if more than 50% is being
amount कैसे decide करोगे आप हिस्ट्री में? फ्रीक्वेंसी बता पाएगा मोस्टली पेशेंट, अमाउंट तो बता नहीं पाएंगे. नोबडी इज गोइंग टू मेजर योर अमाउंट, नोबडी मेजर्स योर यूरिन. फ्रीक्वेंसी ही मोटी मोटी आप डिसाइड कर सकते हो कि he was going once before and now he is going twice, thrice, or maybe 4 times. Okay. Was the need for antihypertensives increase in those 4 to 6 weeks?
No, sir. He was on single antihypertensive agent till 2014. And when he had this rise in creatinine, following which after around 1 month his antihypertensive were also increased. Initially he was on single antihypertensive agent, but now he was started on a second agent also.
Okay, so this was gradually progressive. It would have increased gradually, not over 4 to 6 weeks from one hypertensive to multiple. He has started needing. So something has gone wrong in that 4 to 6 weeks. Maybe as a nephrologist, we always think about glomerulonephritis in our minds. RPRF में RPGN ही चल रहा होता है. But practically speaking, interstitial nephritis also plays a big role. Plus, we don't have a clear serological test to diagnose that. Whatever you read in your text, practically there is nothing to diagnose. So you have to ask your history, where he has taken any drugs. Painkillers are extremely common. Something or the other. Antibiotics are extremely common, especially over the counter. Everything is available in India. So ask that, and the suspicion has to be high, plus biopsy. Second thing, I would say ultrasound. Never go for one investigation completing your diagnosis. If there one investigation is suggestive of CKD, try to repeat the ultrasound probably from a better place, and do the creatinine again. See whether acute factor is there anything. Most of the time these people, let's say they had a diarrhea of small diarrheas, maybe they had gone for some climb or some other mountaineering activity, adventurous activities, and most of what is the first line antihypertensive we used? ACRBs are the most common. So he probably was on ACRB. If he had one of those sick days and he has not taken care of, he had to stop those ACRBs on those sick days, even that itself sometimes can lead to worsening of your renal function, but that's a reversible situation. So going into the details of history in 2014 becomes very, very important. That this is what I wanted to convey. Get into the diagnosis of 2014. Once your primary diagnosis is better, then I think going ahead would be easy. So from 4 creatinine to 9 creatinine, it took 3 years?
2 years.
2 years. Okay. He started dialysis in 2016?
No sir, he did not start dialysis. He was given the options for vascular access creation and the modes of dialysis and renal replacement therapy, but he opted for renal transplantation. So he was not dialyzed, he just received 1 session of dialysis a day prior to the surgery.
Prior to the surgery. Okay, I think we will move ahead.
Should I continue?
Yeah, continue.
The blood group of the patient and the donor was B positive. After a detailed donor and the recipient evaluation, including some immunological test.
वो donor की detail एक बार बता देना. Donor का क्या था?
Donor was his son. Donor's age was 41 years. He did not have any comorbidities.
Okay, fine.
The patient was admitted 2 days prior to the transplant surgery. He was started on tablet tacrolimus and mycophenolate mofetil, and he received 1 session of hemodialysis via left-sided temporary dialysis catheter, femoral dialysis catheter. He underwent renal transplant surgery in March 2017. He remembers receiving a costly injection prior to the surgery and on post-operative day 1 and day 2, which was given as an infusion over 4 to 6 hours.
Okay.
The immediate post-transplant period was uneventful. The patient had immediate diuresis, and during the hospitalization he remembers that his lowest creatinine value was 0.8, and he got discharged after 7 days of hospitalization on tablet Visolon, tablet tacrolimus and mycophenolate mofetil.
Okay. You said he's a lawyer by occupation, right?
Yes, sir.
All of this he's saying verbatim in history? All the medicine, drugs and injections, everything he is telling you?
Yes, sir.
Okay, okay.
Although he does not remember the exact dosage, but names he was able to tell.
Okay.
The DJ stent was removed 1 month after the transplant surgery. He was under regular follow-up, and his immunosuppressants were reduced. He remembers the tablet Visolon was reduced to around 5 mg by the end of 3 months after transplantation. Rest of the medication exact dosage he was not able to remember, but as per him, his tacrolimus levels were periodically monitored and the doses were adjusted.
Okay.
His graft function was stable with the serum creatinine ranging between 1.2 to 1.5 till recently, till 2024. And he did not have any history suggestive of any recurrent urinary tract infections, any acute rise in the serum creatinine, or undergoing any graft biopsies.
Okay.
Patient was doing well till 2 months back when he started experiencing easy fatiguability, difficulty in climbing more than 2 flights of stairs, and walking for up to 1 kilometers, which he was able to do previously. It was not associated with any shortness of breath, orthopnea, chest pain, swelling of the feet, decrease in the urine output, or bleeding from any site. He also started experiencing backache since last 1.5 months. It increased progressively. It was located around the lower back and was present at rest as well as on the activity. It was not associated with any early morning stiffness or any change in his posture. Patient had difficulty in turning around in the bed at the time of sleep, and his sleep was disturbed because of this pain, for which he took some over-the-counter medication, but the pain was not relieved. This pain was not preceded by any localized trauma to his back or any radicular type of pain in bilateral lower limbs. This pain was not associated with fever, night sweats, difficulty in walking, weakness in the bilateral lower limbs, or loss of sensation in the bilateral lower limbs, or any alteration of his bowel or bladder habits. There was a history of significant weight loss, approximately 4 to 5 kgs in the last 4 months duration. There is no history of any altered bowel habits, blood in the stools, frequency or hesitancy of urination, no history of hemoptysis, no history of any yellowish discoloration of the eyes, any hypo or hyperpigmented lesions or nodules over the skin.
Okay.
For these complaints, he visited a local practitioner outside and was evaluated. On blood investigation, he was found to have a hemoglobin of 7.8, and there was a significant decline from 11 gram per deciliter, which was 3 months back.
Okay.
His serum creatinine remained stable at around 1.2 milligram per deciliter.
Okay.
So with these complaints, the patient was admitted to our hospital. Initially, he was started on some symptomatic treatment and he was subjected to some special blood investigations. He also underwent bone marrow aspiration and biopsy, following which he received some injectable medications.
Okay.
In the past history, patient is a known case of hypothyroidism since 30 years and is taking tablet Thyronorm for 75 micrograms per day. He is not a diabetic. There is no history of TB, coronary artery disease in the past. There is no history of any significant surgical procedures in the past. Personal history, patient consumes a mixed diet. The bowel bladder habits are normal. The sleep was normal till 2 months back when he started having severe back pain.
Okay.
And there are no addictions. Family history is non-contributory. Socio-economic history, according to the modified Gupaswamy scale, the patient belongs to an upper middle class.
Okay. Okay. What's your differential?
Differential. Sir, at this point of time, given the constitutional symptoms, significant weight loss, lower backache and significant fall in the hemoglobin, I would like to keep the possibility of chronic infection versus a malignancy. Among the chronic infections, I would like to rule out spinal TB.
Okay.
Or brucellosis, and amongst the malignancy, I would like to keep the possibility of a post-transplant lymphoproliferative disorder or a solid organ malignancy with bony metastasis.
Okay. He's a non-diabetic, right?
He is not a diabetic.
Okay. This weight loss can also be done by sugars. Did he check his sugars before he got admitted with you?
His blood sugars were normal, sir, even during the admission, hospitalization and before
Never had.
hospitalization also.
Okay. There's nothing much to go here. Of course, your differential is fine. Anybody who has creatinine is maintained and has a loss of hemoglobin plus weight loss, nights B symptoms, we have TB or malignancy are the two major differentials that we definitely consider. Anything else that can it be? Apart from TB and malignancy? Brucellosis, I am not sure. I don't think so. I have diagnosed brucellosis ever in my life. Backache के साथ आता है brucellosis? I don't know. Does it?
Yes, sir.
Okay. Fine. What have you asked to rule out brucellosis? It has to have an exposure,
There is no history
right?
of any household domestic pet,
Yeah.
the animal exposure. There is no history of those sorts.
Okay.
But still a possibility cannot be ruled out, sir.
Absolutely. Okay. Go ahead. What else? Next.
So, examination. The patient was examined after informed consent. He was sitting comfortably on the bed, oriented to time, place and person. His height was 170 centimeters and the weight was 58 kgs, making his BMI 20 kg per meter square. His pulse was 86 per minute, regular, normal in volume, no radial or radiofemoral delay, and the peripheral pulses were normal. BP is 110 by 76 millimeters of mercury, comparable in both the arms. There was no postural hypotension.
Okay.
JBP was not raised. Respiratory rate was 18 per minute. Temperature 98.7 degree Fahrenheit. There was pallor. No icterus, no cyanosis, no clubbing or pedal edema. There is no palpable cervical, axillary or inguinal lymph nodes. Spinal examination, there was a diffuse bony tenderness in the lower thoracic and the lumbar vertebra. However, there was no gibbous or any paraspinal fullness. Sternal tenderness was also present.
Okay.
Oral cavity examination was essentially normal. On neck examination, there was no palpable thyroid swelling. On systemic examination,
For that pain, where was the pain exactly? On
sir, it was
location?
on the spinous processes. It was mainly on the lower thoracic as well as the lumbar vertebral spine.
Lower thoracic and lumbar vertebrae.
Yes, sir.
Okay.
On systemic examination in the chest, on inspection, the shape of the chest was.
What is the most common site for tuberculosis in spine?
For
Same as that she is saying. Okay.
the shape of the chest was normal. There was no scar, pigmentation, any dilated vein or pulsations. It was moving symmetrically with respiration. On palpation, the temperature was normal. There was no tenderness over the ribs. However, the sternal tenderness was present. The vocal phragmitis was equal in all the areas. On percussion, there was a normal resonant note in all the areas of the percussion except for the cardiac dullness. And on auscultation, bilaterally normal vesicular breath sounds were heard in all the areas of auscultation, and the vocal resonance was normal. In the cardiovascular examination, on inspection, the shape of the precordium was normal. Apex veet was visualized approximately in the fifth intercostal space lateral to the midclavicular line. On palpation, the apex veet was localized to the fifth intercostal space. It was 2 centimeters lateral to the midclavicular line. There was no palpable thrill or parasternal heave. And on auscultation, first and the second heart sounds were heard normally. There was no murmur or any pericardial rub. On per abdomen examination, on inspection, the umbilicus was midline, it was inverted. All the quadrants were moving equally with respiration. In the right iliac fossa, there was an oblique scar approximately 7 to 10 centimeters. Well healed scar was present. And on inspection, hernial sites and the external genitalia was normal. On palpation, the abdomen was non-tender. On superficial examination, the transplant kidney was palpable in the right iliac fossa. It was non-tender. On deep palpation, no hepatosplenomegaly could be elicited. On auscultation, the bowel sounds were normal. No abdominal bruit was audible. Per rectal examination not allowed by the patient, sir.
Okay.
On central nervous system examination, the higher mental functions were normal. Cranial nerves were essentially normal. The motor and sensory examination did not have any neurological deficit. Deep tender reflexes were normal and symmetrically present, and the bilateral plantars were flexors. The cerebellar functions were intact, and the undilated fundus was examined, which was normal.
Okay. That's it. So, any positive in the examination apart from pallor?
The tenderness, bony tenderness that was there, sir. The sternal tenderness was also there, and the spinal tenderness was also there. Those were the only positive findings, and the pallor.
Oh, what does it suggest?
The possibilities would be post-transplant lymphoproliferative disorders. Even in cases of lymphomas also we can have sternal tenderness.
Okay.
And then even in case of tuberculosis we can have the spinal tenderness. Sternal tenderness we cannot explain by the TB. Then any malignancy with secondary metastasis to the bones. This can present with both the sternal as well as the spinal tenderness. Both could be there, sir.
Okay. Okay, next.
Investigations.
हाँ वहीं पे start कर लेते हैं. So how will you investigate?
Sir, given the possibility of a chronic infection like tuberculosis and the possibility of a post-transplant lymphoproliferative disorder, first of all, we would look for the CBC. In the CBC, we will reconfirm the hemoglobin. We would look for the ESR. Then we would look for the peripheral smear to look for any abnormal cells or any rouleau formation. Then we look for the reticulocyte count also to see if the marrow is hyperproliferative or the hyperproliferative bone marrow, and we will also look for the other cell lines if the TLC and the platelet count is also depressed or it is isolated anemia.
CBC to marrow.
So reticulocyte count that can give an idea of hyperproliferative versus a hyperproliferative marrow.
Okay.
Then in the biochemistries would look for
any role for differential leukocyte counts?
So differential leukocyte count we would want to look for lymphocytosis in the differential leukocyte count.
Any role of monocytes?
Chronic.
You have only two differential here, TB and malignancy.
Yes.
So monocytosis also sometimes, even brucellosis I think has monocytosis.
Yes, sir.
So that was your third differential. So differential leukocyte count definitely helps. If there was more lymphocytes and maybe monocytes, you can think of your other diagnosis. Okay.
Then in the biochemistries, we would like to.
How do you do reticulocyte count? How do you calculate? What was your value of reticulocyte count?
Sir, the corrected reticulocyte count is 2.2%.
How do you do
We
that?
would correct it for hemoglobin because this patient has anemia. So there is a correction factor for hemoglobin that we have to calculate.
There are two correction factors if I am not wrong. What is the other one? Hemoglobin is one. There is one more reticulocyte index. What is reticulocyte index? Correction is index? No.
So
There is reticulocyte count, then there is a reticulocyte index, right? What is reticulocyte index?
Index is a corrected reticulocyte count, sir.
When you correct it for
Corrected
hemoglobin.
sir.
I don't think so. There is one more. I am forgetting the exact formula for reticulocyte index. But there is reticulocyte index and then you do the second correction for hemoglobin. So, I don't know, it's a nephrology class, we don't need to get into hematology, but usually when you do both, most of the time retic count comes down to 1, 2, 2.5, hardly helps us in clinically, but definitely, theoretically, you have to say retic for poor marrow or the other. Any role for MCV? Hello, sir. Good evening, sir. Sir, please. Good evening, sir. Good evening. Sir, please. Just brief कर दो सर को history के लिए.
Sir, I'm presenting the case of a 70-year-old male who is a renal allograft recipient of 2017. Donor was his son. It is an ABO compatible transplantation. The basic disease is most probably chronic glomerulonephritis with a stable graft function and hypertension. Now presented with severe anemia, easy fatiguability and lower backache with a significant weight loss. With this history, I would like to keep the possibility of a chronic infectious process like tuberculosis and post-transplant lymphoproliferative disorders or post-transplant solid organ malignancy with bony metastasis.
Am I missing a point here? I mean, why suddenly go in for, you said post-transplant? 70-year-old
70-year-old male who
presenting with anemia?
Yes, sir. He is a transplant recipient of 2017.
Agreed. And now has presented with?
Severe anemia, bony pains, easy fatigability and significant weight loss with the stable graft functions.
Okay. No fever?
There is no fever.
Right.
On examination,
And
if you have
on
any.
examination, the only positive findings were significant pallor was present. There was bony tenderness in the lower thoracic and the lumbar vertebrae as well as the sternal tenderness was present, sir.
Any bleeding tendencies?
No spontaneous bleeding, any superficial bleed or no history of any GI bleeding, sir.
And what kind of weight loss are we talking here? How much
This
of
is
weight
an
loss?
unintentional weight loss around 4 to 5 kgs in last 4 months.
Okay. So on examination, all that you find is sternal tenderness?
There is spinal tenderness,
Spinal or sternal?
spinal as well as sternal tenderness,
Okay, all right.
and there is pallor.
All right. And the systemic examination?
Sir, on systemic examination there was no organomegaly and there was no palpable lymph nodes also, and only the superficial transplant kidney was palpable non-tender and no other positive systemic findings were there.
All right.
We just started with investigations. So CBC we were discussing.
No, but at this stage. So, if you were to elaborate on what you have thought so far, you've talked about chronic inflammation, chronic infection, right? And anemia. So,
Yes.
what kind of chronic infections come to your mind? You said tuberculosis. Is that all?
Sir, this could be tuberculosis, this could be a bone marrow involvement of the fungal infections like histoplasma. That is also one possibility.
better we not finish there. You have to have a whole list of.
Then in patient with severe anemia and chronic infection, I would also like to keep the possibility of CMV, chronic cytomegalovirus infection with bone marrow involvement.
So any
Parvovirus.
yes, very true. So any objections to, you see out here in these kind of classes, we are more interested in discussing a few points which probably will miss your attention. I mean, everything is there in the books. You can always go back and try to search where would your patient with post-transplant anemia and weight loss will fit in. So she has talked about CMV. Would you agree with that possibility? I mean, it still could be CMV. I'm not denying that, but would CMV be very top on your minds? Any particular reason why I'm raising an objection? That objection actually is.
Sir, so because if there is significant bone marrow involvement by the CMV, then there would be other systemic manifestations, and
True.
the patient will have an acute presentation rather than a chronic indolent presentation.
Yeah, you're right. So one objection can be that CMV is organ specific. If it is a liver transplant recipient, it will generally, that is not a rule, it will generally affect the liver. If it is kidney transplant recipient, I'm not saying it should involve, but it generally involves the kidney. So of course, the suspicion of CMV is going to be because of fever,
Yes, sir.
is going to be because of leukopenia, but then you see, I would expect graft dysfunction. So that's what I mean. So that is why my objection to this would be, since there is no graft dysfunction,
Yes, sir.
I may not keep CMV very
On the
high
top,
on
sir.
cards
Yes.
in the absence of fever, and yes, but then CMV is something which you can be foxed by very, very often, so you can't be dogmatic about any particular. Well, that's right, but yes, parvovirus should always be considered, and parvovirus is, and of course, if you are looking at infections post-transplant and anemia, the first thing, in fact, that I'm not saying the first thing, but then a very prominent thing which comes to mind is parvovirus. And of course, your investigation subsequently will reveal that it's predominantly pure red cell aplasia. It's the lineage affected is hemoglobin rather than. You don't
DHC.
expect too much of leukopenia or thrombocytopenia in a, although that can happen, leukopenia can also happen in parvovirus infection at times, but then predominantly hemoglobin. Okay, tuberculosis, yes. I mean, in India, you will always want, but then again, you see, tuberculosis not giving any fever, you may argue, and you always argue that these are our transplant patients, they don't get fever. Right, it's because of immunity. But then to say chronic infection without fever, tuberculosis is certainly not which comes to mind. Parvovirus can. So that is why we'll go back to parvovirus. CMV can. All that the only manifestation of CMV could be just a GI bleed. Well, you again can say that okay, if it is GI bleed, then this patient did not have any renal involvement, then I should revise my statement. So that was only a subtle hint to you. That's not a rule, that CMV has to affect the kidney and bypass leukopenia and this thing. But then what I wanted to bring home the point is, it is organ specific. People with lung transplants will experience pneumonias more commonly with CMV. Liver will have hepatitis, transaminitis, and kidney patients will have more of nephritis. Right, okay. So, keeping infection as the first possibility in the absence of fever will raise some kind of objection, but you can always argue that fever is not a must in our patients who are immunocompromised, badly immunocompromised. On top of that, he is 70 now.
Yes.
And 7 years post into immunosuppression. Well, okay. Now coming to your other possibility, and the other possibility you said is malignancy.
Yes, sir.
So what kind of malignancy do you have in mind?
Sir, first possibility I would like to keep for a post-transplant lymphoproliferative disorder. The second possibility I would like to keep a solid organ malignancy with bony metastasis.
All right. Anything else? Ordinarily, forget about your patient is post-transplant patient, but your patient is 70.
Sir,
Your
plasma
patient
cell
has-
dyscrasias.
So why shouldn't we keep? So a patient who is 70 has anemia, has spinal tenderness. Obviously, you will think of either plasma cell dyscrasia, myeloma, frank myeloma, or metastasis.
Yes, sir.
When you talk about metastasis, then again, you see, you will have to divide your patients, malignancies which are unique to
Transplant patients.
transplantation, and malignancies which can happen in any 70-year-old gentleman. But sternal tenderness from your MBBS days raises something else, rings another kind of bell in your mind. So what is that bell?
Sir, lymphomas,
No, before
leukemias,
leukemia.
acute leukemia.
So the moment, you see, I will be expecting, I would have expected you to come out with leukemia, because sternal tenderness, the first thing which comes to mind, बच्चे जितने भी देखते हो, sternal tenderness is leukemia. So obviously ये सब बहन भाई हैं, lymphomas, leukemias कोई अलग-अलग थोड़ा है, it's the way we perceive them or way we look at, but जब आप जाते हो, it is that cell है तो lymphocyte से काम शुरू हो रहा है ना, चाहे उसको जो मर्जी नाम दे दो, इधर से उधर से घुमा दो.
Yes, sir.
So sternal tenderness you can't, and that is why I had asked you specifically any bleeding tendencies.
Yes.
So if you have sternal tenderness, and if your patient says that while brushing his or her teeth in the morning, that's among the first few things. Petechiae, gum bleeding, and sternal tenderness. That tenderness, these could be just the only things. Well, yes, okay. So we've talked about infections. We've talked about malignancies. Any other, before we start the formal discussion in today's case, and we'll come back as to what it really turns out to be, any other possibility which you may want to keep so that we should not have ignored any once the final diagnosis is made clear? Any other?
Osteoporosis or because of the corticosteroids long term, patient can have fractures, elderly patient.
Yes, but then again, okay, that could be an additional finding. But to be able to knit everything together, you have to factor in the anemia, the weight loss, and then, so obviously we will want to sum it up into one.
Myelofibrosis.
Sorry?
Myelofibrosis.
Myelofibrosis,
Haven't here made
weight loss also. Again, sternal tenderness and this thing. So I don't know whether that clue is taking anywhere. So I would always keep the common things first. So if I have kept 90% of the things which were anticipated in my differential diagnosis, I think my job is done. It may turn out to be anything. Like today we saw a case of West Nile virus. I had heard a lot, so I was glad that finally I came to see a patient who's been diagnosed as West Nile fever. West Nile. So I mean, if I miss West Nile fever is one of the causes of fever, I won't mind. But if I miss dengue as a cause of fever, obviously I'll curse myself. So that's the, so myelofibrosis less likely. But any other this thing? So let's now, for the sake of discussion, divide our patient into possibly some infection or some malignancy. If we were to consider some malignancy, so let's start as to what are the malignancies which come to, starting from you. What are the malignancies which come to mind when you are talking about your patient of kidney transplantation with some possibility of a cancer? Which all cancers come to your mind?
Solid organ transplant.
Yeah, we are talking about solid organ transplant. We are nephrologists, so
Colon cancer can be there.
sorry.
Colon cancer can be there, sir.
All right. Renal. breast cancer. So my residents will tell you, and this is very famous this thing. So pardon me out for the sake of repetition. They will tell you. Now Chaitanya is already last. वो कौन सा थी मूवी, कौन सी थी, नाम बताओ पहले. हाँ क्या थी, क्या नाम था? सो मूवी में वो जहाज़ चला रहा है, जो W वाला 10 जिसमें एंड में गोवा में निकलता है, खजाना डबा हुआ है, वो जहाज़ चला रहा है. वो नीचे उससे ग्राउंड कंट्रोलर से पूछता है कि मेरे को जहाज़ चलाना नहीं आता है, तो कहता कोई बात नहीं, हम तुम्हें सिखाते हैं. और वो फाइनली बोलता है कि मेरे को वहाँ एक लाल बटन है. कहता हाँ 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 मिल गया, मैंने दबा दिया. कहता वही बटन नहीं दबाना था. सो अब आपको याद रहेगा, सिर्फ एक बटन था, वो है ब्रेस्ट कैंसर, जो नहीं दबाना था. ठीक है जी. कौन से 2 बटन हैं जो नहीं दबाने हैं ट्रांसप्लांट के बाद?
ब्रेस्ट एंड ओवेरियन कैंसर.
ब्रेस्ट कैंसर और प्रोस्टेट कैंसर वाला बटन नहीं दबाना है, क्योंकि ये 2 कैंसर हैं जो कम होते हैं. अब याद रहेगा. चलो अब आगे चलते हैं. So skin cancer, so you will divide your patient into few categories. जो कुछ कैंसर एकदम से दिमाग में आते हैं, मतलब ट्रांसप्लांट के बाद कैंसर हो गया, अरे हम तो बच गए, बिकॉज हम तो मतलब ब्राउन्स हैं, हम तो बच गए हैं. तो जाके देखो ऑस्ट्रेलिया में और कनाडा में और क्या हो रहा है इनके साथ. वो तो
The other one is what is more common. You have to start with common first. You can't say colon first. Skin cancers post solid organ transplant. Skin cancers being the most common. Start with that first.
So any cancer of the skin is a good answer. So you will divide them into those cancers which have more than 5 times the chances of occurrence. और 4-5 है, कटक से नाम याद आने चाहिए. Alright? So उसकी जनरल पॉपुलेशन में होएगा नहीं होएगा, बट देन अगर ट्रांसप्लांट है कैंसर, इसको स्किन होगा. स्क्वामस सेल, बेसल सेल बाद में आता है, लेकिन ये होगा. ऑलराइट. लिप कैंसर, वल्वल कैंसर्स, ठीक है, एंड PTLDs, Kaposi sarcoma, नॉन मेलानोमा स्किन कैंसर्स, Kaposi sarcoma. सो दीज आर Kaposi sarcoma. वैसे चाहे रेयर होए, लेकिन ट्रांसप्लांट सेटिंग में 5 टाइम्स ज़्यादा. सो 5 टाइम्स वाली लिस्ट ही अलग है. And then you will say those cancers which are very common. And which are those very common? PTLD उसमें आ गया. PTLD में मतलब आपने skin cell carcinoma किया, and then is PTLD, and then is Kaposi sarcoma, and then are the lip, the vulval, this thing. So these are fine. But high cancer वाले फिर उसमें किडनी आ जाएगा, लंग आ जाएगा, कोलन तो सबसे नीचे पड़ा हुआ है, कोलन बहुत थोड़ा. So in order of infrequency we will say breast बहुत ही कम, prostate कम. ऐसा नहीं है कि किसी को आपने prostate cancer से बचाना है तो उसको बोलो तो ट्रांसप्लांट करा ले, तो ये नहीं है, मतलब but the incidence is less. ठीक है. So these are the kind of cancers which come to mind. So today our discussion, since he is leading us towards some kind of malignancy, which is obviously the fear. If your patients do not die of infections or cardiovascular disease post transplantation, they are going to die of disease in the occurrence wise, the commonality wise. Good numbers, I may be wrong, but then more than 20% deaths post transplant, and well functioning grafts also are because of malignancies. Talking about malignancies, so first you will say the eras have changed. The way we used to look at malignancies during the times, because when we started it was like cyclosporin era. We are lucky that we had cyclosporin available. I mean, just about 5 years when I became a nephrologist, there was only azathioprine and prednisolone, Dexa, 100 milligrams of that kind of thing, and azathioprine toxic doses. This is what they had. So cyclosporin was a game changer. Then the scenario shifted from the kind of cancers shifted. So what are the kind of cancers? With azathioprine, you were seeing what? You were seeing more squamous cell carcinomas. Squamous cell carcinomas were more common with azathioprine, right? And with the CNIs, what happened? All kind of malignancies came into picture. Why? Because you know cyclosporin, or for that matter the tacrolimus, it promotes TNF alpha and so all these fibrotic things. So, they are the one which perpetuate the malignant cycle transformation. Kaposi sarcoma is interesting. Has anyone seen, or we just heard, we read a lot about Kaposi sarcoma. Let me see, I don't remember.
HIV.
Sorry?
We've
Yeah.
just heard in HIV sometimes such a
Yeah,
Kaposi becomes
Kaposi
very common.
sarcoma typically is HHV, HHV8, all right. I don't know whether I have one. I'll show you if K. No, I'm sorry. Then I know it's more like there are vesicles kind of thing. So, it's all studied the body. It's get it. The one look at this thing violaceous and this thing. So, they are all over the cystic lesions and the blebs kind of things all over. The typical violaceous thing over the lower limbs. So, one you must go and see, and it's very rewarding to see them disappear once you put them on mTOR inhibitors. So, we started talking about the effective role played by mTOR inhibitors the moment we saw Kaposi sarcoma disappear with the introduction of sirolimus. There was in one series, I remember there were about 17. We were in the process of writing when I saw that patient, and I still remember the figure 17 patients, some series somewhere, where sirolimus was used and total disappearance of Kaposi sarcoma. In the same breath, we talk about mTOR inhibitors in other malignancies. That's why we thought it's a panacea for all kind of malignancies, which is it is not. So, it's not. So, we'll come back to that. All right. So, we have talked about those malignancies. You can check the list. I could be wrong. Please do verify. All that I remember offhand is the skin cancers are very high, but you must remember that there are cancers which have more than 5 times the incidence of that of the general population. So, you must know them, and then you must know those cancers which are found with very high prevalence in solid or post-solid organ transplants. PTLD is yes, but PTLD is not the commonest malignancy. It's the second commonest malignancy. You said PTLD now. Coming to your and let's raise now you will probably raise your objections to why PTLD in 7 years post transplant. What kind of PTLD are you thinking?
Sir, the late onset PTLD is usually the second peak of PTLD is seen beyond 5 years of transplantation, and these are usually EBV negative PTLDs. And these sort of PTLDs usually are more common in the elderly population as opposed to the EBV positive PTLDs.
So, this is a very common statement which we keep on hearing, that the first year post transplantation, if it is a PTLD, it is generally Epstein-Barr virus positive, and when it is it has a bimodal occurrence. When it is beyond 5 years, it is EBV negative. Then what is it?
But still, it is the prevalence of the EBV negative PTLD is more in the second peak, but still out of the all, still the possibility of EBV positive is more out of 100 patients.
Agreed. I am asking a little different question. Agreed that even in the late onset, you may still encounter EBV positive patients, but by and large they are EBV negative.
Yes.
If they are EBV negative, then what is the cause? You see, first you can say, okay, it's a virus, it's Epstein-Barr virus, right? But if it happens after 5 years and you are not able to find any virus, then what is it? They are still non-EBV viruses. So, or they believe that EBV was in such a low concentration that it's undetectable, but it is doing its damage. So, remember this, there has to be an enemy sitting there. It's not. So, why does, before we think, have you ever seen a case of PTLD?
Yes, sir.
Not this one.
Not this one, sir. There was
So,
a
this
patient.
means that means this is it. Right?
No, this is not
Okay.
the patient.
So, has anyone seen PTLD?
Yes, sir.
Yeah. Okay. So what comes to your mind when we are talking about PTLD?
Usually, lump is there, or the patient I saw, they have liver lesions. They have patient had symptoms of early satiety, abdominal fullness, and when an ultrasound was done, the liver was enlarged and there were lesions which were present on the liver.
That must have been late onset.
Yes, sir.
That this is typical presentation of a late onset PTLD. While the initial is a typical classical lymphoma in children, young age groups, Epstein-Barr virus positive, where you did not care to check or you still were bold enough to go ahead with the transplantation and also give ATG induction in a patient who was Epstein-Barr virus antibody status negative, IgG negative. So what happens? So there, what kind of PTLD symptoms? These are common things which you must know. ये कहना कि PTLD हम सोचेंगे? No. The typical is fever, lymphadenopathy, nasopharyngitis is the word I want to use. So when you say PTLD, the typical presentation could be nasopharyngitis, and that's all. And then you have lymph nodes. You biopsy them. It turns out to be PTLD, and then is the next step. Anyone wants to volunteer to throw more light on PTLD? Starting from the gentleman on the extreme right. PTLD? Have you heard of the term PTLD? Yes. It's common, you will always agree, yes. You will always remember. It is, if it is the first 1 year, it is likely to be Epstein-Barr virus. All right? So, I have a different way. What I am trying to do is not to confuse you, but we'll try to form a consensus and then later give us the diagnosis, the final diagnosis. All right. So we would be curious to know whether this could be PTLD. So we have divided PTLD into two varieties: early onset, first 1 year, and late onset beyond 5 years. The first ones are Epstein-Barr virus related, associated. So what is the pathogenesis? Anyone? Very interesting. Why are we making a villain out of ATG? ATG is a wonderful drug, and तो क्या हो गया? T cell करती है, तो करती है T cell तो.
So T cells.
It will lead to the unregulated proliferation of the B cells in which the EBV resides.
Very good, very good. So typically the Epstein-Barr virus is going to go into the B cells and reside there. There is going to be an exponential increase in the proliferation of these kind of cells which are having Epstein-Barr virus. So all these are kept into check by T cytotoxic cells. All right. If you remove the cytotoxic T cells, their growth is going to be unregulated now. If there were T cells, the matter will finish and you label it as infectious mononucleosis. No one is scared of infectious mononucleosis. All right. But if the same thing was happening and you were to take away our natural defenses against an enemy called Epstein-Barr virus, you are creating trouble for your patient. So that is why. So it's very good. So this is how you can expect Epstein-Barr virus related lymphomas, PTLD. So can anyone tell us what kind of lymphomas are there? 6 types. अब 6 बताने पड़ेंगे. अब फिर प्रॉब्लम है. Again, my advice to everyone would be, ये 6 वाला काम ना बोलो. अब प्रॉब्लम हो जाएगी 5 बोल के सारा क्रेडिट चला जाएगा. अब 6 बताने पड़ेंगे. बैठ के. That will be the least.
Yes, sir. Monomorphic and polymorphic B cell.
Monomorphic. 1,
Polymorphic.
2.
Infectious mononucleosis line.
चलो नहीं, क्लासिकल नहीं है, but then okay.
एक plasmacytic proliferative type.
Okay. ना चारू है. So that is why the trick is, so we'll start with जितने याद आ गए. So the common चीज़ जो आप नहीं भूलना चाहिए वो है monomorphic. That is the commonest. We'll come back to that, but gradually. So ये Epstein-Barr virus आया, इसने कुछ किया. So एक चीज़ होती है non-destructive. पड़ा मरियल सा Epstein-Barr virus से कोई destroy भी नहीं कर सका, कुछ बिगाड़ भी नहीं सका वो. They are hypertrophic, hyperplastic, जो भी नाम दे दो. Infectious mononucleosis is a part of these non-destructive lesions. 1. Then you have polymorphic. Almost they are malignant cells, पर पता नहीं कौन थे. है malignant, बड़े खूंखार लग रहे हैं, बट पता नहीं क्या है. बी सेल है, टी सेल है, पता नहीं क्या है. टी सेल भी होता है लिम्फोमा, सुना कभी?
Yes.
T cell lymphoma भी rarely होता है. All right. Monomorphic is what we are all the time worried. If this case turns out to be monomorphic, then obviously he is doomed. 7 years post transplant, the average, I would have seen at least about 14-15 cases of late onset post transplant lymphoma. None survived for more than 6 months or 7-8 months, except maybe one maximum. All right. So monomorphic is one, and out of monomorphic we are predominantly DLBCL, you know, diffuse large cell B cell lymphoma is the dreaded word, and that's what we generally encounter in all of these cases. And then finally is your favorite, classical Hodgkin lymphoma. So all these are non-Hodgkin lymphomas. Monomorphic are all non-Hodgkin lymphoma. DLBCL is one of them, but there are many others. They're all non-Hodgkins. And then finally is the Hodgkin lymphoma. So I would tend to break them into 4 PTLDs, regardless whether they are Epstein-Barr virus associated or Epstein-Barr virus negative cases. So this is about PTLD. So when it comes to other kind of lymphomas, you must always remember there are a few others as well. कौन से हैं?
Burkitt's lymphoma.
Burkitt lymphoma can be seen. We don't get to see it. I don't think we see. It's more with the African countries and this thing. But then जहाँ पे होता है, this is a very deadly thing. And also the CNS lymphoma is a different ball game altogether. CNS lymphoma is another very dreaded thing.
Yes.
All right. Anything else you would
So
have?
the T and the NK cell lymphomas.
Sorry.
T cell lymphomas and the
T cell
natural
lymphoma
killer
is a
cell
very
lymphomas.
rare thing. So if you forget about it, if you say no, हमें तो सिर्फ B cell सुना जी मैंने, you'll be right. You'll be passed. But then T cell lymphoma is this thing. So किसके साथ कौन सा होता है? Epstein-Barr virus के साथ PTLD, HHV8 के साथ Kaposi. बाकी बताओ.
सर HIV के साथ Merkel cell lymphomas होता है.
कौन सा? Merkel cell.
cells.
MCV virus can cause. HIV के साथ एक और होता है कुछ.
Even Kaposi also and diffuse large B cell also is there.
HIV के साथ कुछ और होता है.
CNS lymphomas.
HIV के साथ कुछ और होता है. Plasmoblastic lymphomas is a very rare entity. एक दिन न्यू इंग्लैंड जर्नल ऑफ मेडिसिन में या AJKD में एक केस रिपोर्ट थी HIV के साथ, and it's synonymous with the plasmablastic या plasmablistic ऐसा कुछ. So that's a very rare, and that's generally seen with HIV. So these are so we've talked about skin. Thankfully we are blessed, we are living in India, we are not encountering too many of skin malignancies. I tell you, I don't know whether we have missed, hopefully we have not missed too many of skin cancers, but then hota hi kam hai. Something which is the very commonest malignancy elsewhere in the world, we don't get to see too many of squamous cell carcinomas. Basal, you know, basal is not a big deal. Basal ka kaat doge theek ho jayega. Basal is not a dreaded thing, at least to my mind. But squamous is, squamous mein to matlab bahut bura haal ho jayega. And of course all the even melanomas, we are all the time talking about non-melanoma skin cancers, but then melanoma also is right. And then we've talked about whole lot of other malignancies. But when you look at lymphomas, आप बात कर रहे हो plasma cell की. Why not plasma cell leukemia? ठीक है. So PCLs, these are plasma cell leukemia. Try to envisage them as one common entity. है तो सारे plasma cells ना, है तो सारे lymphocytes. उसी का नाम दे दो, उसको T में ले जाओ, उसको B में ले जाओ, उसको करा दो. और myeloma क्या है? वो भी तो plasma cell ही है, उसी में से निकला है कुछ, वो कौन सा किसी का सगा है. And plasma multiple myeloma.
Yes, sir.
I won't be surprised that it turns out to be multiple myeloma. Tenderness, spine tenderness, उसके है. Anemia उसको है. So this is what we've said. तो 70-year-old है, ना भी ट्रांसप्लांट कराया होता तो भी तो ऐसा थोड़ा कि ट्रांसप्लांट करा के उसका माइलोमा इंसिडेंस कम हो जाना है, वो तो रहना ही है.
Yes, sir.
And उल्टा बढ़ जाना है माइलोमा
Yes, sir.
इंसिडेंस. ठीक है, it is not a very common this thing. Then you will have to, people may ask, आप तो अपने solid organs की बात करते हो, वो hematologist बोलता है अभी बहुत छः आ गया है, हमारा एलोजेनिक स्टेम सेल ट्रांसप्लांट कर दिया हमने, अब इसमें malignancy आ गई, उसमें कौन से आएंगे? उसमें PTLD नहीं आएगा, ठीक है, उसमें कम होता है, right? So the way, so you have to remember all these things. So दो चीज़ें तो पक्का याद रहेंगी आज, कैंसर ब्रेस्ट नहीं बोलना, प्रोस्टेट नहीं बोलना, ठीक है ना जी, ये चीज़ तो रहेगी याद. दूसरा I'm glad you could answer that. क्यों होता है? T cells बचाते हैं और T cells ही आप ले जाओगे अपने पहरेदार ही खड़े सुला दोगे तो घर में तो दुश्मन घुस आएगा. That's one. Now the one thing common with these majority of the malignancies is one blood test which you should always rely on. What is that test? एक मैं बोलूँ आपने CBC कर लिया, CBC में अनीमिया आ गया, उसमें ESR बहुत ज़्यादा आ गया, वो तो आप कहोगे तो अनीमिया की वजह से है. आपने ल्यूकीमिया के सेल्स देख लिए. It could be जैसे as we said, we don't get to see too much of leukemia thankfully in adult population, but then we've discussed that it could well be a leukemia. I mean not the typical AML हो जाएगा, AML it could be AML that we know, it could be ALL as well. But LDH is something which you should always remember. As nephrologists, learn about these things. The way you think about CRPs, when you look at CRP of a patient, this few things come to your mind. Infection, HSCRP तो हार्ट की तरफ चले जाते हो, इधर है तो इन्फेक्शन की तरफ चले जाते हो. Similarly, LDH does not always mean hemolysis. LDH could mean some hidden malignancy. Always view it with suspicion. Hyperuricemia, never ignore hyperuricemia. It could be the only thing which could be suggestive of some kind of malignancy in your high turnover. Cell की turnover ज़्यादा हो रही है, alright? So, and of course we will come back to this thing. So now you tell us about the. So I think I hope you like this format, because we must first brush up our knowledge about post transplant malignancies and then reach to what we have for today. So eyes see only what the mind knows. So unless your mind knows what we are this thing, so whatever she says, she'll quickly refer to an LDH of 600, and then you listen. You will not be able to register because you don't know the importance of LDH till the time you have been told about that. So let's now hear her telling us about the labs.
Just to complete that.
Yeah, please, Arun, over to you now.
What are the risk factors for PTLD would be one question.
Extremely
what are
important.
most common question asked in Viva? What are the risk factors for PTLD? Which transplants will have it more? Which transplant will have it less? Like we were discussing, like Sir said, hematopoietic stem cell transplant will have it less. So what are the risk factors?
In terms of the organ being transplanted, the risk of the PTLDs is more with the small bowel transplants, followed by the lung and the heart transplantation, then followed by the liver transplantation, and it is least with the kidney transplantation. Then in terms of the induction therapy given, it is the risk of PTLD is more with the T cell depleting agent as opposed to the non-depleting agents. Then in terms of the cumulative dose of the immunosuppression, the longer the immunosuppression given, the more are the chances of developing a PTLD. Then the patient's seropositivity or seronegativity in terms of the Epstein-Barr virus. If the recipient is seronegative and the donor is seropositive, he has the highest risk of developing a PTLD. Then if the recipient is an elderly patient, even the males have a higher chances of developing PTLDs. And
extremes of ages.
Extremes.
If the child is young and especially unfortunately is not seroconverted to Epstein-Barr virus, that's and on top of that, as I said, if you give an ATG, you fall in trouble. But one important thing which you are missing, which you should always remember, there are some other factors as well.
Then there are even donor derived factors also. If there was undiagnosed malignancy in the donor, that also could be a source of PTLD.
That's true for any malignancy, not just lymphomas.
Yes, sir.
Any malignancy. So lymphoma, it's less applicable to lymphomas, but more to other malignancies where you have donor transmitted malignancies and donor derived malignancies. There are two kinds, two separate entities, DTT and DDT, which would means donor transmitted and donor derived. So there are set criteria, there are set patterns to know. You are then doing immunohistochemistry to find out where there is this, the way you do donor derived cell free DNA, where did it come from, similarly. But anyone, you'll make my day if you tell me what are the HLA types which are associated with PTLDs. I am very fond of numbers, let me tell you, and I just don't like wrong numbers being given. Very good. 26. HLA A26. Remember, HLA A26, B18 and probably B40 are worst hit, while HLA3 is protective. You don't get to see too much of lymphomas in people who have HLA-A3. And there was something with A1 as well. There's possibly A1 and A3 which are better, but please do check all these numbers. But I am dead sure about A26 because we have reported a case of PTLD which is one of the rarest of the rare entities. I think you may have heard that case being presented in one of the forums as well, whereby he presented with a young boy and mother was the donor, and they gave basiliximab as induction. He developed acute rejection. They gave him very high doses of ATG, and then he developed nasopharyngitis and lymphadenopathy and was found to have lymphoma. And we, in our wisdom, that is when he came to us. It was transplanted elsewhere. We treated his lymphoma, got cured, but in our wisdom, because the literature tells us to do that, we reduced his immunosuppression, and we had a lot of faith in mTOR inhibitors. We shifted him to mTOR inhibitors, and he developed bad TMA, and the graft was lost. And then after a waiting period, so please go through that. Pallavi from our Pallavi, you know, Dr. Pallavi, who is at Safdarjung, used to be at our hospital, and she did a very good job to present this very nicely written article. It is in the, what do you call, Japanese journal, case reports. Very good impact factor. So, it is there. So then we thought of doing a retransplantation, and the challenge was the patient was still EBV negative. I mean, the first was one done. Thankfully, they gave basiliximab, but unfortunately, because of that basiliximab thing, he had rejection and now had to be given ATG. And in a patient who was Epstein-Barr virus negative status, 10 doses of, or maybe 6 doses or whatever, high doses. And then even at the time when we considered him for a second transplant, which means there had to be waiting period of 2 years. So 2 years in remission after successful treatment of PTLD. When we thought about accepting him for a second transplantation, he was still Epstein-Barr virus. On top of that, father, who was this time the donor, had Epstein-Barr virus PCR positive. So we had to wait. Thankfully, he cleared, the father cleared his virus, and he, for some reason or the other, suddenly became Epstein-Barr virus positive. So we went ahead, we did the transplant, and then you can discuss now which immunosuppression, which induction will you give, what kind of immunosuppression will you give, how to check Epstein-Barr virus. So that is why I say, if you want to read more about PTLD, there are just about 67 cases. The largest series is about 531 of a huge registry. But in the anecdotal cases, 1 or 2, and then 52 is the largest French series or that kind of thing. So retransplantation obviously had to be just a very few. And unfortunately, and we took all precautions. Epstein-Barr virus was checked regularly. He was given extended valganciclovir, because you remember Epstein-Barr virus has no antidote. The only antidote we use is valganciclovir, which has been found to be fairly effective. Ganciclovir, acyclovir, they reduce the incidence rate. So we used it, and then after 6 months of valgan, we changed it to acyclovir, which we've continued throughout. Lifelong we were planning. Unfortunately, 2 years down the line, he again had a lymphoma, this time in the intestine. So that was removed. Again chemotherapy, touch wood, so far he's doing fine. A brilliant boy, is doing fine, but fingers crossed. I mean, it's been so lymphoma, recurrence of lymphoma post successful replantation, that makes it even more rare, I would say. So, and there are cell markers. I don't often remember. It's there in our article, W something, WI, or these are the score which the hematologists use. KI score, 135 or KI something, that kind of thing. Yeah,
more than 50 and less than
more
50.
than
More than
50
50 are more aggressive.
So they guide us towards the treatment of lymphomas, those immune markers, so PTLD. So where were we? So we lymphoma, we talked about PTLD, we've talked about generally HLA typing is important. I mean, you must know, थोड़ा सा आपको याद होना चाहिए, A3 and A6, 6 है शायद, आप देखना, A3, HLA A3 and A6 are protective, and I believe A1 also is protective, while 26 is notorious, B18 has Chaitanya said is another one, and I think it could be 40. I'm not too sure about 40, but okay.
So these transplant workup, we are going towards non-doing HLAs and going by DNA fingerprinting and
Yeah,
probably
but
this
you're
will-
right. You're right. So
I have
that is
not done
why
HLA for
we
last 2
must-
years.
Yeah, but we must do. I think we make our patients spend double the amount of money. Of course, we have to abide by what the law says, but then I would be very curious to know, even in a spousal donation, why not? And in consanguineous marriages and whole lot of things, that is one. But even otherwise, we are living in a similar same community. So many times you have 2/6 match in a wife also and a husband also. Why not? We must know, and we can play around with immunosuppression much better. Anyway, that's let's not deviate. Coming to any other thing you want to know from her?
Probably just to over that statement where sir said you have a renal transplant, so renal for CMV and ABV, it will come through that.
Yes, sir.
The organ specific thing. Probably that, especially in that patient who has EBV positive donor and a EB negative recipient, probably it is because of that organ specificity where for the positive organ has gone inside the negative person, and then it has regenerated. So organ specificity might come from that aspect as
Yeah,
well.
definitely. Why not? Yeah, it could be the explanation. Yes. Yes. So, any other thought? We've talked about. I think we must have talked about most of the malignancies which we generally fear. And please remember, renal cell carcinoma is notorious. Never ignore those cysts. The acquired cystic. See, remember now another button नहीं जहाँ दबाना. ADPKD
is not the risk factor.
yes, so उसमें बटन नहीं दबाना. But acquired cyst में ज़रूर दबाना. Acquired cyst has a very high chances of malignant transformation. All right. So renal cell carcinoma, and we've recently seen. And remember, I mean आगे चलते जाओ क्या thought process होना चाहिए. Acquired cyst, renal cell carcinoma, amyloidosis. You remember वो secondary amyloid को याद है आपके गंगाराम की मीटिंग में आपने कहाँ बढ़ाया था वो डॉक्टर अतुल कक्कड़ ने वो नीचे लिखा हुआ था renal cell carcinoma amyloid. We have seen that in one of our patients amyloid निकला है renal cell carcinoma में. खैर वो और बात है उसको Angst-Pond से amyloid है, but then at least differential diagnosis तो आप रखोगे. So, but renal cell carcinoma, coming back to our discussion point, is of common occurrence in patients with this. So never ignore cysts. So please do get a routine ultrasound once in 6 months. अगर patient के cysts हैं आपके, because otherwise अगर cysts नहीं हैं post transplant they will involute, और अगर नहीं है तो नहीं बनेगी. This is generally believed. All right. But जब बन चुकी हैं, you can't be sure कि वो involute करेंगी. They may increase and they may undergo malignant transformation, especially under the effect of immunosuppression. And coming to your answer, that it's the prolonged, it's the immunosuppression vintage which has a lot of bearing, and that is why in these kind of situations where you dread lymphomas, PTLD और बच्चों में जहाँ पे Epstein Barr virus status नहीं है, तो आप उसकी immunosuppression CNI की डोज कम कर दोगे. Because still remember हमारे इरा में skin cancers, आपके इरा में lymphomas, so that's the difference, right? So, right, let's move on. The next या कुछ और एक important चीज़ आई थी, पर चलो. और टेस्ट आपके क्या बताते हैं आपने पूछोगे कौन से टेस्ट?
CBC, we just started with CBC
All right.
and a differential leukocyte.
आप
count,
बताओ
what
जी
is
कौन कौन
important.
से टेस्ट आपने कराए?
So should I tell patient's investigation or the evaluation?
आप नहीं, नॉर्मली ऐसे पेशेंट में क्या कराओगे? पेशेंट की हम एंड में बात करेंगे. ऐसे पेशेंट में आप क्या क्या टेस्ट करवाने चाहोगे?
First the CBC along with the peripheral smear to look for any atypical cells or any blast, and also to look for the ESR in the CBC with total leukocyte count and the differential count and the platelet count. And also since the patient has anemia, typing of anemia, MCV I would like to look for, and the reticulocyte index. Then in the biochemistries I would like to look.
इन सब malignancies में anemia सबसे profound कौन सी malignancy में होगा? MCV तो नॉर्मल निकला, लेकिन MCH, MCHC दोनों कम है. So it's iron deficiency.
Yes, sir.
किस में?
Acute leukemias.
और कुछ? Acute leukemia में iron deficiency नहीं होगी.
Then GI malignancies
So
with
first thing
blood
is
loss.
in a male 70-year-old anemia, and if it turns out to be iron deficient anemia, I will take it very seriously and explore his colon GI
Yes.
system to look for a cause, because iron deficiency can and should never be ignored in a male. All right? So, all right.
Then in the biochemistries, I would like to look for the serum creatinine values, the calcium and the phosphate levels, sodium and potassium levels. I would like to check for the total protein count, the albumin and the globulin, and uric acid levels, sir, and the ALP levels. In the liver function test, I would like to see for the any rise in the SGOT or SGPT levels. In and the LDH, I would like to check in this patient. Then I would like to also see for urinary examination in this patient, urine for any proteinurias, and urinary protein creatinine ratio, the urine dipstick as well as the urine protein creatinine ratio, to look for any albuminuria versus protein non-albuminuric proteinuria. Then I would like to check for the ultrasound of the whole abdomen to look for any enlarged lymph nodes or any organomegaly, and any
कोई और blood investigations में I may have missed that point. Did you talk about protein electrophoresis?
no sir, not yet.
So we see 70-year-old, how can we ignore the importance of serum protein electrophoresis, free light chain ratio? I mean, that should be incorporated whenever you are encountering anemia. So anemia, and on top of that we are talking about malignancy, and on top of that we are talking about tenderness, spinal tenderness. Did you talk about PSA?
I was coming to this, not
Blood
yet.
तो खत्म कर दिया आपने, आप तो अल्ट्रासाउंड पे पहुंच गए. So
So in the blood on special on further investigation,
this
I
is not
would,
a special. PSA is a routine, should be a routine in any 70-year-old
I
person.
would like to check for beta 2 microglobulin also, the free light
वाला
chains,
बटन नहीं दबाना चाह रही.
Personal prostate नहीं बता रहे.
the PSA levels, free total to free PSA levels, and ESR I have checked.
यूरिन में
Even the
malignant
tumor
cytology
markers
देखना
like
ESR
carcinogenic
बोला ना,
antigen.
ESR
हाँ जी sir.
हम बोल दिया ना. नहीं, ट्यूमर मार्कर्स हम बाद में कह सकते हैं, because they'll be really this is not the basic investigations is what should include PSA and should include protein electrophoresis. Now these are not reserved investigations. So these are something which we do on a routine basis while एक second. Hello.
Even in urine, when you're considering RCCs, there you have to do for urine for malignant cytology also you can do before you
मैं क्लास में
go for
हूँ, मैं वहाँ
ultrasound.
किसी की ड्यूटी लगा रहा हूँ.
That also is one.
एक सुनील है उधर, मैं भेजता हूँ. एक मिनट एक काम करो, राजकुमार है, मैं राजकुमार को भेज दूँ. मैं बाहर आया हूँ क्लास लेने के लिए. आई एम सेंडिंग समवन, या अमनदीप को मैं बोल रहा हूँ. अमनदीप, राजकुमार चला जाएगा साथ में और अमनदीप को करेगा. मेरी वहीं बिलिंग में मैं कराता हूँ बात. All right. So you said ultrasound, and then we will also get the tumor marker. Would you have some faith in these tumor markers? Even otherwise, forget about transplant patients. They have generally been not found to be of much utility, even in the general population. So the same, like routinely getting a screening with CA19-9 and CEA or 125, CA125. Because yes, if you have clinched the diagnosis, maybe they may offer some kind of utility, but then to do them just to prove or disprove malignancy may not be appropriate. So we would rather, in this kind of scenario, so we have choices beyond ultrasound of either getting a CT scan done or straight away go in for a PET scan.
Stool for occult blood.
Yes, that will be very important, especially if it turns out to be iron deficient anemia. On the other hand, all right. Any other thought which comes to mind, so that we don't get surprised by what she is finally going to tell us as the diagnosis? All right. So This patient, what did you find?
Sir, on the complete blood count, his hemoglobin was 7.4, his ESR was 140, the reticulocyte count was 2.2%, corrected reticulocytes. His total leukocyte count was 6,400, with the neutrophil being the predominant cell, 64%. Platelet count was 1.3 lakhs, and on typing of the anemia, it was normocytic normochromic anemia, and no abnormal cells were seen on the peripheral smear. His serum creatinine was 1.2 milligram per deciliter. His sodium was 140 and potassium was 3.7. His calcium was 8.5. His total, the adjusted calcium was 9.4, sir. His total protein was 13.9 with the albumin of 2.8 and globulin of 11.1. ALP was 66. His total bilirubin was 0.6, direct was 0.2. SGOT and SGPT were 22 and 26. LDH was.
So, what are the various conditions which come to your mind when we are talking about this kind of AG ratio reversal?
So, one is multiple myeloma,
2,
chronic liver disease,
3,
tuberculosis,
4,
and
autoimmune
Autoimmune
disorders,
disorders.
SLE, all autoimmune disorders, all right. And then it could be any other malignancies as well, not. It could be malignancies,
yes, sir.
not just myeloma, but it could be lymphomas also, right? All right.
On urine routine examination, sugars, proteins and blood was negative and no active sediments were there. On urine protein creatinine ratio was 0.6 milligram per
Urine
gram.
protein creatinine ratio.
Protein creatinine ratio, sir.
Okay.
And on dipstick protein was negative.
Okay.
His
But did you get the urine albumin creatinine ratio done as well? No.
no, sir, it was not.
So it was
done.
just protein and okay, all right.
We got a serum immunoglobulin concentration and serum protein electrophoresis done. In serum immunoglobulin, there was a rise in the IgG levels. It was 95.6, and on the serum protein electrophoresis, there was a monoclonal band in the IgG region. And on immunofixation, it was type 2B IgG kappa band, and his beta 2 microglobulin level was 8.2. And on immunofixation, we got the typing of IgG kappa, following which we went ahead with the bone marrow aspiration and PET scan. In the bone marrow,
How much was it? No, immunoelectrophoresis you said is for kappa,
yes, sir, kappa, IgG
Right.
kappa.
right? And
The ratio was 11.1, sir.
now, so how do you interpret this electrophoresis? Will this does it mean that your patient has multiple myeloma, or could it still be something else? So AG ratio 13 total protein, 2.8 of albumin. Look at about almost like 11 grams of globulins, and it turns out to be kappa on immunofixation. Does that mean that this is multiple myeloma, or could it be something else as well? It's kappa, it's IgG, he said. So,
Yes.
if it is IgG, obviously it is not Waldenstrom macroglobulinemia, all right. So, it is not Waldenstrom. What else could it be? Can it still be PTLD? It still could be PTLD. I mean, it's not, myeloma is not the only thing where electrophoresis comes as positive and kappa. But then yes, you are now being led more towards myeloma and this thing. But then you see myeloma, this bad lymphoma not causing rise to hypercalcemia and hyperuricemia also at the same time. I am not implying that hypercalcemia is a must for, I mean CRAB is not a must, I mean you have to have other myeloma defining events. But then to have this kind of advanced, so much of this thing and nothing happening to the kidney, nothing happening to the kidney. राजकुमार वो हेल्प करानी है इनकी, देखो कैसे करनी है, जरा अपने अमनदीप को फ़ोन करो, मैं मीटिंग से निकल के बात करूँगा अमनदीप से। हाँ, जो भी बेस्ट करा सकते हैं अमनदीप को बोलो बिल्कुल आना, और उससे बात कराओ जरा पिनाक को बोलो जरा इमीडिएटली सबसे बात करके करे जो मैक्सिमम कर सके। ऑलराइट, okay, so you went ahead and did the bone
PET
marrow
scan and the bone marrow, sir.
Yeah. So what did the PET scan show?
Sir, in the PET scan there were
But
Multiple
did you get a bone scan done?
No, sir. We did directly PET scan.
PET scan.
Yes, sir.
Yeah.
There were multiple FDG, avid and non-avid intraosseous lesions, and they were expansile osteolytic lesions which were involving the appendicular skeleton predominantly, with the sternal and the spinous involvement, and scapular involvement was also there, sir.
All right. So, what was the differential diagnosis of these lesions, of these findings?
This was myeloma-like illness.
Right. Any other? They were osteolytic. Right?
There were no lymph nodes to go for the lymphoma per se, and no organomegaly also, sir. And no avid lesions, no avid uptake in the liver or spleen.
Osteolytic. Okay.
The bone marrow aspiration was done.
They were expansile.
Yes, sir. They were expansile lesions.
Okay. Then
And in the bone marrow aspiration, the marrow was cellular with predominantly around 45 to 50% of the plasma cells, and no other abnormal leukemic cells were seen, sir.
right. So, what becomes your diagnosis now?
Now it is multiple myeloma, sir.
So, why
With
multiple myeloma? Is there any myeloma defining event here? The cells
There
were
is
not
anemia.
60%?
There is anemia. There is lytic lesions on the bone. There is bone involvement. There is significant anemia, and there is more than 10% plasma cells in the bone marrow. So this
the
becomes
criteria?
myeloma.
Right. So, you have more than 10%?
Yes, sir.
You
45%.
have radiological, yeah, but
Yes,
more
sir.
than 10%.
Yes, sir.
You have radiological lesion,
Yes, sir.
and you have anemia,
Yes, sir.
right? So, any other thing? So, crab में क्या होता है? Crab? So, bonely lesions कितनी? कितनी bonely lesions? हर चीज़ specific है. More than equal to 1. Anemia less than
Less than 10.
renal more than
More
renal,
than 2 milligram per day.
ठीक है, and calcium, ठीक है. So, your patient has multiple myeloma.
Yes, sir.
Is it in any way related to the transplant, or he was destined to have multiple myeloma?
Sir, although the chances of multiple myeloma as compared to the general population increase post transplant, but given the age of this patient, the incidence of myeloma at this age group is also higher. So we cannot at this point of time say if this is because of transplant or per se there was a.
Is there any way you can say that okay, this could be related to the thing? So any other, the way we have Epstein-Barr virus markers, or is there anything in, I don't know, I don't know the answer to that. It's just a thought. Is there any way by which you can differentiate between?
We can only differentiate if this myeloma was donor derived or not. That can be done using DNA fingerprinting and the genetic analysis of the donor as well as the recipient. But in the patient per se, if this is related to the transplant or not, this is not, we are not able to differentiate.
So donor derived hota hai, it will not happen after 7 years.
Yes, sir.
So that's the one. So it is recipient driven.
De novo it is.
De novo or this thing, but then I don't know the various markers, if they help you in any way post transplant, the anti-CD138 cells, if they are in any way different in these two populations. That's the question which I was asking. I don't have the answer to that. All right. So the diagnosis is that your patient, so always we come back to where we had discussed. In a 70-year-old, forget about the transplant or not, right? So that was the statement. Forget about the fact that he or she is a transplant patient, but the gentleman is 70-year-old, has anemia and has spinal tenderness. So the first thing I would be keen on ruling out or confirming would be multiple myeloma. And that is why I said serum protein electrophoresis should have been a part of this, and at least in this patient.
Yes.
And this is what I generally do, and I generally tell all the students, the residents, that whenever it is unexplained renal failure in a female, you will not be excused, pardoned, if you don't send an ANA immunofluorescence. In an elderly male or female, unexplained renal failure with anemia and you don't investigate on the lines of multiple myeloma, again it's a crime as a nephrologist, because general population may not be seeing that kind of myeloma, but then we as nephrologists we see a lot of myeloma, because the moment किसी की creatinine बढ़ी नहीं तो आपके पास आ गए और आपने anemia देख के भी अगर नहीं सोचा तो मिस किया तो रेयर चीज़ें 30-year-old में myeloma मिस कर दोगे, I won't mind, but 70-year-old में मिस करोगे, it's not good. How would you treat such a patient now? He has a well functioning graft and you will have to be.
The immunosuppression needs to be reduced and the chemotherapy needs to be started. Since he has a well functioning graft and there is no renal involvement per se, we could have thought of triple drug therapy of chemotherapy, which would comprise of proteasome inhibitors, the immunomodulators and the prednisolone. But the immunomodulators lead to acute rejection episode. There is increased chances of acute rejections. So in a well functioning graft, we would want to prevent that. So we would begin with the 2-drug therapy.
Which one? Which immunomodulator causes higher chances of rejection?
Sir, thalidomide and lenalidomide both, they will
out of these two, lenalidomide.
Lenalidomide, sir.
Yeah. So that's more notorious.
Yes, sir.
But you should be happy with bortezomib. We use bortezomib so very often, so we are quite familiar with its usage. So that of course. Supposing your so this is a scenario where you will of course very cautiously treat and keeping a balance into this thing. What do you believe is going to be the general outcome? How much years of life can you really add on in this particular person?
So given the newer therapies that are available like anti-CD38 monoclonal antibodies and the proteasome inhibitors, the overall survival can be improved beyond 7 to 8 years and the progression-free survival could be somewhere beyond 5 to 7 years. But still these patients have increased chances of relapses. That is bound to happen.
So always remember, myeloma is not curable. Myeloma is only controllable. So but yes, you can certainly make. Would you consider after achieving remission, you know, well, let's not go into the details of treatment of myeloma. You heard it recently in the nephro-onco, whatever. After those 6 months of intensive therapy and now it's a maintenance regime, would you want to consider this gentleman, had he been 68 years old, 65 years old, for a bone marrow transplantation?
Sir,
after 6 months?
Sir, with the recent reviews and the guidelines, it is being said that first we have to define the risk status of the patient, the myeloma risk stratification. If this is a high risk patient and he is eligible for the bone marrow transplantation, then after giving the induction therapy, we should go for chemoablative therapy and the hematopoietic stem cell transplantation. But if it is a standard risk or a low risk patient and we have achieved enough remission of the disease, then we can also give the patient the option of a delayed bone marrow transplantation, which is being said that we can even wait till the first relapse of the disease. But this has not been very extensively proven, only the case reports are there, sir.
So scenario certainly has changed with the availability of daratumumab. It's terribly expensive, prohibitively expensive, but then it's a game changer. So you certainly see much better response rates in people. So obviously, as he has said, you divide these patients into bone marrow transplant eligible, non-eligible. So everything will revolve around whether your given patient is, and there are a whole lot of new therapies coming up as well. So very exciting field for myeloma. But supposing now let's go back. If this patient at the age of 55 was diagnosed as multiple myeloma and went into remission with chemotherapy. Obviously, as we said, it may not be a cure. At that point in time, and he was found to have during this period end-stage kidney disease, and he remained on dialysis. What would be your thought process as to when to offer him a bone marrow transplant and a kidney transplant? So, which first? How long to wait for?
Sir, it is being said in various case reports that we have to achieve a sustained remission for these patients to be eligible for a renal transplantation. So, like the Mayo Clinic's guideline as well as the International Myeloma Group guidelines, they say that it is better to go for a bone marrow transplantation, achieve a sustained remission, then go for the kidney transplantation. And the timing of the transplantation for renal transplantation, it is again being decided by the patient risk stratification. If suppose this patient is a low risk patient and there is no minimal residual disease, then we can go with the bone marrow for the kidney transplantation after giving a hematopoietic stem cell transplantation and waiting for 6 months. If this patient is a high risk patient on the fish stratification, but still there is no minimal residual disease, then we can go ahead with the renal transplantation after 1 year of hematopoietic stem cell therapy. But if this is a high risk patient along with the residual disease, then either we should wait for more than 2 years duration, or if this is a formidable condition, then we should avoid renal transplantation altogether if the overall survival is less than 5 years for the patient.
So I'll tell you what we did in our patient where we faced a similar kind of challenge. I'll just take a minute. जल्दी क्लास चल रही है. क्यों क्या हो गया? थोड़ा नमक वगैरह देके देखा है कुछ? नमक लिम्का में नमक डाल के थोड़ा देखो जरा. चल ठीक 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 ठीक. So end stage kidney disease, we found out that the reason for end stage kidney disease was myeloma. Started treatment myeloma, remained on dialysis, bone marrow transplantation after 6 months. Now the real challenge, how long after? So the literature is divided. So we were criticized that because we went ahead with kidney transplantation on just after about a year of sustained remission and post bone marrow transplantation, right? But then we stood by it, and I still would believe that's the way forward, because it's not a cure. You in any case have to give them bortezomib based therapies or otherwise, or nowadays if one can afford retumumab. So I don't think we should wait for very long because the chances of them not doing well on hemodialysis post bone marrow transplantation, etc. etc. So anyway, that's for some other day. But then you must know there are periods. So the way she has described, you should look at the risk factors. There are the chromosome abnormalities, you know, the trisomies, the high risk where you would be more scared of not being able to achieve remission. All right. So I think that's it. We've had some good discussion about, and then you please go back and read about the risk stratification of multiple myeloma, who are eligible, who are not eligible, how do you treat, what do you do after 6 months of remission, when do you offer a kidney transplantation to a patient on dialysis after bone marrow transplantation having achieved remission, and how do you treat this kind of patient whereby it happened after 7 years. So if it had happened after 7 years, what are the, and supposing it had turned out to be lymphoma, what would have been your strategy? So let's go back to PTLD, that's a commoner variety. Multiple myeloma we can discuss a number of times, but lymphoma, again you must remember, if your patient is Epstein-Barr virus positive, you may want to, obviously you will give them rituximab, all right, with or without CHOP. So it will be R-CHOP or just R, depending upon whether your patient can take it or not. If your patient can take it, is young, you will give full blown R-CHOP, and of course in Hodgkin's lymphoma the other variety. So but the rule is, if it's Epstein-Barr virus negative, you may not want to give rituximab. Yes. On the other hand, what would be your strategies to prevent PTLD in a patient who is Epstein-Barr virus thing? You can see, आप कभी करवाना, आपके patients में Epstein-Barr virus PCR कराओगे positive आ जाएगा. That doesn't mean they are heading for lymphomas. उनमें भी AG ratio थोड़ी ऊपर नीचे हो जाएगी. You start fearing कि ये तो myeloma होने वाला, lymphoma होने वाला. But a low volume of I think 700 per 100 microliter per 100 microliter copies is okay, is ignorable, while more than 4,500 copies of Epstein-Barr virus should not be ignored. So again, the relative concentration of Epstein-Barr virus can tell you whether lymphoma is going to come up or not. All right. If it turns out to be positive, what are your mitigating strategies?
First of all, we have to reduce the immunosuppression medication. We have to reduce the dose of immunosuppression and see for next 2 to 3 weeks if there is decrease in the copy number of the Epstein-Barr virus or resolution of the lesions.
अगर बढ़ गया तो?
If they are increasing, then we have to go for, if it is EBV positive lymphoma, then we are thinking, then we have to go for rituximab
Very
therapy.
good. So this is where in the rising cell count Epstein-Barr virus, you can think of giving them rituximab. Otherwise, अगर आपका एक young child है, transplant कर दिया, Epstein-Barr virus negative है, so the preventive strategies would be galcyclovir.
Yes.
All right, so valganciclovir, ganciclovir, intravenous ganciclovir people have given for 100 days, then followed up with acyclovir or valganciclovir. There's not much data, I believe, of valgan, but हो सकता है. So I think I'll take it in this talk about the two in the same breath, valgan or ganciclovir alone, right? And rituximab is something which is very, very important to prevent lymphoma in a patient with rising Epstein-Barr virus count. And the cutoff आप फिर दोबारा check कर लीजिएगा. I believe it's 4,500. While low variety and not increasing variety of Epstein-Barr virus, you can ignore.
तो ये रूटीन ट्रांसप्लांट में करना है
ये
जो
routine
आपके ओपीडी फॉलोअप्स पे आ रहे हैं
करना चाहिए. So that's the way we are looking at. So this is how knowledge should get enhanced. You see, पहले तो आप BK वायरस नहीं कराते थे, अब आप BK वायरस को छोड़ते नहीं हो. आप CMV को तब देखते थे जब कुछ हो जाता था. So I think पहले घर के दरवाजे खोल दो, फिर चोर घुस जाए, फिर उसकी पिटाई करो. So better है दरवाजे बंद कर लो. So पहले ही थोड़ी अकल कर लो और BK वायरस को भी कर लो. And the same breath, why not Epstein-Barr virus? All right? हम proactively अगर करें, I don't know, cost is always a factor, but given a choice, अगर आप अपने पे बीतती है तो आदमी कहता है अगर मेरे को ऐसी सिचुएशन हो जाएगी, मैं पार्वो वायरस को जब करोड़ों में हो जाता है तब मैं ढूंढूं, तो why not कि मैं उसको पहले ढूंढ लूं so that I cut down on immunosuppression. एक बड़ी इंपॉर्टेंट चीज़ रह गई इम्यूनोसप्रेशन में. आपने बोला ATG, आपने बोला CNI की वजह से, आपने एज़ोथेप्रिन के बारे में नहीं बोला, करता है. आपने MMF के बारे में नहीं बोला. ये बटन नहीं दबाना था बच्चे, ये बटन नहीं दबाना था. आपने गर्दन ऐसे कर दी MMF के ऊपर.
Sir, MMF is anti-proliferative.
So
and
ये
azathioprine
बटन
is
नहीं दबाना है. MMF does not predispose to
PTLDs.
PTLD. क्लियर? सो क्या चीज़ें सीखी हमने? ब्रेस्ट कैंसर नहीं होता, प्रोस्टेट कैंसर नहीं होता, और MMF कल्प्रिट नहीं है. रिमेंबर, MMF कल्प्रिट नहीं है. हर चीज़ में नहीं कि CMV में भी उसको विलेन बना दिया, पार्वो वायरस में भी उसको विलेन बना दिया. एंड आई गेव अ वेरी, आई डोंट नो आप लोग आए थे कुछ के नहीं, आई गेव अ वेरी वेरी कॉन्ट्रोवर्शियल स्टेटमेंट, बट आई स्टैंड बाय इट. आई सेड इवन इन BK वायरस, एक 2011 वर्ल्ड अमेरिकन जर्नल ऑफ ट्रांसप्लांट में, I'll share with you the interesting article whereby they said cyclosporin is protective against BK virus and possibly so is BK and MMF. और आप तो सबसे पहला काम करते हैं MMF बंद कर दो. MMF हर जगह में विलेन है. CMV में मान लिया, कहीं औरों में भी, पार्वो वायरस में भी मान लिया, कहीं में मान लिया, but then it may actually have a protective role against CMV, against BK virus, but unfortunately उसको किसी ने घास नहीं डाला. और all the guidelines including the most recent guidelines on BK virus will say cut down on or stop the antimetabolite. So azathioprine और MMF के सबसे पहले रात आपकी बरसती है. All right, but you go through that World Journal Transplant, American Journal of Transplant 2011 article. I'll give you the reference. Otherwise आप BK virus देख लेना, AJT and 2011. And there's an article why it may have a protective role. Like cyclosporin has protective role against hepatitis C, parvo virus. You remember? No, even BK virus. So cyclosporin बड़ी अच्छी दवाई है. It has antiviral properties against Hep C, against BK virus, against parvo virus. Right? So अगर use करनी है तो use करोगे. But MMF malignancy नहीं करता because it has anti-proliferative action. Sirolimus नहीं करता. क्यों नहीं करता sirolimus? Has
Anti-VEGF and anti-angiogenic.
P70, I am very fond of numbers, P70 S6K of sirolimus. Remember, it works via that pathway, P70 pathway, which is protective against this thing. So, this is why mTOR inhibitors are this thing. Clear ji? Questions now. Now, reverse.
I will start with the first. Should we decrease the CNIs and get into mTOR inhibitors once you diagnose PTLDs or some sort of malignancies post transplant? See, in which the four immunosuppression strategy with TSCNI will come down and everyone might be
you're right. So this is what is generally believed, and we did it in our patient as well. We burnt our fingers, and he had terrible rejection. He was a young boy. So answer, and the other thing which comes to mind is shift them onto mTOR inhibitors. Now mTOR inhibitors may be working more as good prophylactic agents, including in BK virus. Once BK virus happens, the mTOR inhibitors may not do much, but if you put them on mTOR inhibitors up front de novo, maybe this is what Transform told us, that in those patients who were enrolled in the Transform trial, de novo mTOR inhibitors, they did not encounter too much of CMV or BK virus. But once BK virus happens, and आप कहोगे अब हम change कर देते हैं, so same thing happens with PTLD. mTOR inhibitors have anti-cancer property. बंद कर दो CNI, लो कर दो CNI, MMF हटा दो. MMF protective था. MMF हटा दिया because you have to now bring in mTOR inhibitors. So it will have to be one thing making way for it. And which is that way? Which is that molecule? It's mTOR, is MMF. MMF हट गया. CNI आपने कम कर दी. In a young person, because EBV हुआ था, वो इम्यूनो कॉम्पिटेंट है, लड़का यंग बंदा, तो खूब ताकत है उसमें. वो तो जैसे ही आपने एक मरियल सा एंटी दिया, वीक इम्यूनो सप्रेसेंट्स दिए, टेरिबल रिजेक्शन. So this is what looks like. So I don't have an answer to, but then going by that, what we did in the second time in the same patient, we did not give him mTOR inhibitors the second time. He is being maintained even at the time when he had recurrence of PTLD. We still continued him on a relatively low dose, but I think I have always maintained his TAC levels between 4 and 5. That's so at least his kidney is safe, but then I don't know eventually what is going to happen. It's been 2 years of remission after that resection of followed by chemotherapy again, and the chemotherapy also changes depending upon the cells. So I don't think we can go into the territories which is being mastered by the hematologists these days, but we need to have some decent knowledge about, so that we have an active role to play in the management of operations. So they look upon us to guide them as to what needs to be done. So that I hope that answers. So no one really knows.
Once it has already happened, it does not.
Very few cases. We think. Any question? Reverse epidemiology.
Sir, I just wanted to ask, like in the differential diagnosis, in some places they have included multiple myeloma as plasma cell disorder along with the PTLDs. So when we talk about the differential diagnosis of these kind of patients, should we say PTLD separately and multiple myeloma as a different?
Yes, so it will not be easily digestible by most of the people who are going to examine you. So I think it is better to play safe. But then they say we have clubbed them under lymphoproliferative disorders. So well, PTLD is a different ball game altogether. You remember जो आपने बोला, the patient you had seen hepatomegaly, this thing, and then the commonest presentation is many years after transplant, diarrhea. Intractable diarrhea. You've done the colonoscopy, you do a superficial biopsy, you are going to miss the diagnosis. So it has to be biopsy within the biopsy, it has to be submucosa which has to be taken out, biopsy into a biopsy. And of course PET has made our task rather easy. It'll show you all FDA avid nodes, and then if luckily you find easily accessible lymph node, so that makes the diagnosis easy. GI bleed. My first encounter with this thing was when I was just 1 year into practice as a nephrologist, and one of a very VIP patient, someone very close and dear to me. We lost him to terrible this thing, and we were all, I had no personal experience, it was all bookish. So we scanned the literature and found out that no, this must be this must be CMV. It turned out to be CMV, and then subsequently we know the presentation after recurrence, and then finally whether that led on to PTLD in any way, or maybe it was an Epstein-Barr virus sitting somewhere and ultimately myeloma, ultimately PTLD. So PTLD should be thought about whenever you have a patient with lymphoma, with the diarrhea and hyperuricemia. Hyperuricemia again, never ignore it, never ignore it. LDH. All right, और कुछ anyone?
What was the induction agent used in the patient you described second time?
It's basiliximab again. So we of course the literature is divided. The French people, they say that they have used ATG as well, but remember ATG has almost like 21% higher chances of PTLD. ATGAM, not ATG. ATG का तो फिर भी 5-6% है. Thymoglobulin, the rapid ATG has 21%. ATGAM has 26%. ATG has about 6%. Campeth has very high chances. फिर कर दिया नीचे. ये 4 ही तो बटन जो नहीं दबाने थे. Campeth नहीं करता है PTLD. तो भाई याद रखोगे. अब ये आएगा. Campeth is synonymous with dreaded Campeth है ना. So Campeth lymphoma नहीं करता है. कौन करता है?
OKT3.
OKT3 सबसे ज़्यादा टॉक्सिक. ओह वेरी गुड. OKT3 तो हमने यूज़ किया हुआ है. We were among the last few when OKD was available and very toxic, very toxic. जैसे एक तरफ फंगिसोन चल रही होती थी, वो शिवरिंग, तो आपने तो देखे नहीं हो, आपके पास एम्बिसोम है. आपने कभी जो डीऑक्सीक्लोरेट यूज़ करते हो तो देखो क्या हाल होता है. तो वही हमारे पेशेंट्स के साथ होता था. बट रिमेंबर ऑन ए सीरियस नोट, alemtuzumab has not been associated with high chances of lymphomas. Remember this. All right? जो मैं सुनना चाह रहा हूँ, belatacept. So belatacept is notorious. All right? Although there are few people believe. एक बड़ी इंटरेस्टिंग चीज़ थी, belatacept ने उन्होंने देखा कि they said कि जितनी immunosuppressant strong दोगे, now I am proving your point wrong. आपने बोला ATG देते हो, strong देते हो, तो लिम्फोमा हो जाते हैं. हमने एक मरियल सी दवाई दी belatacept, और रिजेक्शन तो प्रिवेंट करती नहीं है, लिम्फोमा कर देती है. सो इसने फ़ायदा तो कुछ किया नहीं, लिम्फोमा ज़रूर कर दिया. सो इट्स नॉट नेट स्टेट ऑफ इम्यूनोसप्रेशन. एक और थी, वो पता नहीं उसके belatacept के साथ एक और रेवलूजीमैब एक और दवाई इसके साथ ही, नहीं इसी के साथ आई थी. belatacept के साथ एक और स्टडी आई थी, eluzumab, again an immunosuppressant, very weak immunosuppressant, caused good chances of lymphoma, but this was not potent enough to prevent rejection. Clear होगी बात? So आप 4 बटन दबाओ जो नहीं दबाने. बताओ जी, कौन कौन से नहीं दबाने?
We should not
और
talk about
पिक्चर तो नाम तो बता दो भाई. एक तो आपसे रिक्वेस्ट की थी दमाल. हाँ, दमाल कहता है 4 बटन काम से नहीं दबाने.
We should not say prostate or breast malignancy as increased chances of
Multiple myeloma, MMF.
MMF should not be, and alemtuzumab.
And net state of immunosuppression is not a very this thing. There are many other factors because belatacept बेचारा मरियल सी चीज़ वो भी कर देती है.
Okay.
So remember belatacept good. Clear? और कुछ अब हमें कुछ ज्ञान दो जी, बताओ. हाँ, रिवर्स गुरु दक्षिणा बोलो.
अगर प्री ट्रांसप्लांट एबीओ कंपेटेबल और एचएलए कंपेटेबल दोनों ट्रांसप्लांट हम कर रहे हैं, डोनर सीरो पॉजिटिव है, रिसिपिएंट सीरो नेगेटिव है, तो बस वॉलस्टेड टोटल ड्यूरेशन मतलब कितने के लिए लेना है, या फिर हमें ईबीवी मॉनिटर करना है?
नहीं, आप दोबारा सॉरी, ईबीवी की बात कर रहे हो, सीएमवी की कर रहे हो?
ईबीवी.
So EBV में the people generally believe that you should give for 200 days because valganciclovir is still the only tool you have against this thing. No one knows the answer whether prophylactic rituximab has a role to play or not. So I don't have the answer to that. किसी के पास नहीं है. So people may have tried, I don't know. हमें हिम्मत चाहिए. But the only tool which you have to your rescue is valganciclovir, जो आपको 200 days देनी चाहिए. I personally, the kind of experience very little which I have, I would be very happy to give acyclovir 200 milligrams or maximum 400 milligrams for maybe another 2 years. And more importantly, what you need to do is keep on checking their Epstein-Barr virus PCR status. Not we're not worried about antibodies. वो कैसे बनेंगे? पहले PCR positive आएगा, IgM आएगा तो IgG बनेगा ना, तो सीधा तो है. So you should monitor their Epstein-Barr virus. So that's again, I think, there's something which is a lesson to be learned. Please do see your patient's Epstein-Barr virus status. Varicella करो ना करो, कर लो तो और भी अच्छा है. वो इसलिए नहीं कर रहा हूँ क्योंकि आपने वेलगैनसाइक्लोविर तो देनी है, वेरिसेला भी साथ ही में बहती गंगा में हाथ धो लेगा. ठीक है ना? और ठीक है, ओके, चला जाए.
Just last thing on mid state of immunosuppression.
ये क्या हो गया? ओह यस, भाई आप लोगों के लिए गुड है, रिमाइंडेड मी, थैंक यू वेरी मच. सो ये सर्कुलेट कर दो सब में. दैट्स फॉर यू प्लीज, दैट्स फॉर हर. एंड आप लोग जरा जस्ट सर्कुलेट. सो इट्स बेसिकली फॉर यू. I have a strong belief that please, PD needs you all. PD is a wonderful modality of treatment. It is being ignored. It has almost, I don't want to use the word, but then I'm compelled to, that it's become a dying art for various reasons. So please accept your responsibility as budding nephrologists to take this mantle forward and not allow it to die a slow death. It's a wonderful, let me tell you, I am quite passionate about peritoneal dialysis. It's a wonderful, if you have seen good results coming out of it, you will be I think a big fan of this modality. But you will have to show a lot of interest. Please do that. It is good, I can only assure you that. Now this is a selfless service which you can do to your patients. This may not give you any, it is not a paying thing. So don't even have that in mind. So it is like one-way traffic. You will only be investing a lot of time, effort, energy in your patient's welfare and not expecting anything in return. But please do that. And I can say that because I have been fortunate to have country's longest survivors always as my patients, so I know how much effort is to be put in. One person last year completed 21 years, and it's only after he migrated to Canada, unfortunately he was found to have sclerosing peritonitis, and then they stopped and he's now on hemodialysis. His brother lived for 17 years on peritoneal dialysis. Another patient lived for 15 years. 3 of my patients have crossed 10 years and are surviving. One is into 14 years, and there are patients whom we had thought will die within no time of chronic liver disease, including one from Agra. She has already completed 3.5 years on peritoneal dialysis, where we thought even doing her hemodialysis was out of question. Blood pressure is 80, 60, and on top of that she had what do you call, where you do a lot of APCs, the GAVE, right? So there's huge lot of whole lot of success stories, and I think I always say, you will keep on hearing this from me, what differentiates you from not so fortunate ones is the one thing which is around our shoulders all the time. That's one, but that's as a doctor. But as a nephrologist, what differentiates you from others is you are the ones who know about dialysis, others do not know. You are the ones who know about transplantation. And if you are talking about dialysis, you should talk about PD and hemo in the same breath. It is not without reason that PD first policy is in place in countries like Mexico, Hong Kong, Thailand. So it's widely prevalent. So please master the art of peritoneal dialysis, and that's my very earnest request. But till the time you actually do it yourself, you will not get a kick out of it. Till the time you set up that cycler overnight, you will not get a kick out of it. Until the time you actually perform a few exchanges, and once you are able to to set the fluid overload of a patient right without resorting to hemodialysis and ultrafiltration, if you can do it with the help of peritoneal dialysis, it will be very satisfying. We were compelled to have more faith in PD because hemo was not widely prevalent, and if the patient comes in the middle of the night, there was no technician willing to come to the unit in any of the government hospitals doing dialysis, hemodialysis for you. And the only way of the means of survival for these patients was a bedside intermittent PD. Would do wonders, would do wonders. वो कैसे करना था, struggle, एक फिर दोबारा करो, फिर थोड़ी देर बाद सिस्टर की कॉल आ जानी, फिर ब्लॉक हो गया, फिर खोल दो, तो पेशेंट ठीक हो जाएगा. How many of you are going to join us on 18th of this month at auditorium of Max Hospital Saket? Few more, and all of you. So this is basically for all of you. Please do encourage everyone and all your friends to learn. We'll try to have a very concise. So this should be, this kind of meetings which are we going to organize on the 18th, I believe should be organized much more often, so that you get a hang of it. But then whenever you come across these meetings, please go back and request your respective unit heads to have the similar kind of enthusiasm about PD, so that you learn, and ultimately आप लोगों ने चलाना, हम तो spent forces हैं, ठीक है. All right.